following program contains many scenes of common sense. Viewer attention is strongly advised.
Anyone know what this is, class? Anyone? Anyone? Anyone seen this before?
A dose of reality. This may be one of the most important curves that you will ever become familiar with, especially when it comes around to recommending medications, prescribing medications, and so on. And I'm sure you've seen this in your studies. And at the time that you saw it, you probably sort of went, oh God, it's so desperately boring to look at dose response curves. And that's exactly what this is. It's a dose response curve. And what I want to do is talk a little bit about why it is so important for you to understand some of the concepts of it. So on the y-axis, we have the percent of patients responding, or say the percent of the response, anywhere from 0 to 100. And on the x-axis, we have the actual dose. And it's really important to realize that this is almost always described as a log dose. And that'll become quite important for you to remember, because it'll show you the differences as we increase or decrease doses and what it does to the percent of patients responding, or the percent of the response. But the first thing that I want to let you guys know is the recommended doses in these books are wrong for most people. I'm not saying this because an evil cartel is trying to get people on much, much higher doses, but there's a whole rationale for why that's the case. And as I said before, I think if you can understand the concept of a dose response curve, it may be the most important concept to understand when it comes to prescribing. So if you can understand this concept that we're going to go through, I can almost guarantee that if you use these principles, you'll produce fewer side effects, there'll be less concern or fewer drug interactions. And one of the cool things is you can definitely reduce costs of medications. So let's sort of examine this curve in detail. Obviously, you can see that this curve interacts at around 20%. And typically, when you're looking at most medications, you get a placebo group response around 20%. Obviously, that varies depending on the condition. For our purposes, we'll just say that this is the effect for placebo. The placebo group response can vary. It can vary from around 40% for people with panic disorders. It could be maybe 30% for things like blood pressure, depression, and anxiety, and so on. A little bit less for menopausal symptoms, chronic migraine, 20% for Alzheimer's symptoms and acute headaches, 10% for erectile dysfunction and OCD, and as low as 5% for people who are, definitely having a psychotic event or hearing voices and so on. And then, of course, you have general anesthesia, for which there's no sort of placebo group response. So we have this spectrum of placebo group effect, generally is around 20%. And then we have medications that are very, very effective and will work in almost everybody. Things like local or general anesthesia, benzodiazepines, especially if you can give enough, insulin, and so on. And then typically when we're talking about the effect of a medication, for instance, things like antidepressants, antihypertensives, and probably a good chunk of medications, we get an overall response of around 50 to 60%. And then we have to take that into account with what goes on in the placebo group. So let's start with a generic medication. Let's say it's 100 milligrams. And roughly speaking, in this case, you can see if you went over to the percent of people who are responding, you can see the effect is somewhere between 70 and 80%. Now, if you were to go down to 50, you can see that you're still getting the vast majority of the effect, even though you've cut the dose in half. And even when you cut the dose by, in this case, a 20th of the dose, you're still getting some benefit above the placebo group effect. It may not be, it's obviously not as big as what you'd see with 50 and 100, but you still have some effect, and you at least get sort of a 20% placebo group effect, regardless of whatever dose you use. And here's a really good example of what happens when we change doses of statins and the percent reduction that we see in LDL cholesterol. I'm just using this sort of as an example. So on the y-axis, we have the percent of response. That's how big a reduction we see in LDL cholesterol. And then on the bottom is the different types of statins that we have available. So if you were to give sort of a 10 milligram dose, you can see that the reduction in cholesterol is somewhere around 20 to 45%. Now, if you double the dose to 20 milligrams, you do see a greater reduction in LDL cholesterol, but we're not seeing in any way, shape, or form a doubling of the effect. You can see that we're maybe getting another 5, maybe 10% reduction in LDL cholesterol. When we go to 40 milligrams, or 4 times the dose, we squeeze out a little bit more reduction in LDL cholesterol, but the vast majority of the effect we're still seeing from just the 10. And when you go to 80, you get a little bit more, but even increasing the dose by 8 times, you still are not getting much greater effect than you are seeing with the initial 10 milligram dose. And so this is a wonderful example showing that you get the vast majority of the effect from a medication from the lowest dose. And so this is just a way to sort of think about it. If you were to give, let's say 100% of the effect was with 80 milligrams, you still get 95% of the effect with 40 milligrams. You get about 85% of the effect with 20 milligrams and 75% of the effect with 10 milligrams. So this is just a very good example of how you don't lose much effect by cutting the dose in half and then half again and so on. We see this with many medications. Atorvastatin is an example. I've already showed you. This is what it would look like on a dose response curve, 80, 40, 20, and 10. And in fact, we have very little data on what happens when we go to below 10. But you can imagine if you cut it in half again, you'd still get a reasonable effect on cholesterol or LDL levels. Another really good example is the inhaled corticosteroids. The percent of people who respond to, say, 1,000 micrograms of whatever corticosteroid, in this case, sort of fluticasone, if you would cut that dose, you still see the vast majority of people getting a benefit from 250 and 125. You see, again, a reduction when you get to that sort of steeper part of the curve, but you still get a reasonably good proportion of people or percent of people responding to doses that are, in this case, just about a tenth of what we originally started with. One of the best ways to sort of think about this is we all know that there are sort of a dose response for alcohol. People have different responses to what will make them throw up or get drunk or whatever. And there really is no way for us to figure that out. There's no sort of CPS or PDR that says this is the dose that you should use. And almost all of it, from almost everybody's experiences, is that we learn what the correct dose is for an individual by sort of trial and error and titration. And I'm sure many of you know a number of people who are very sensitive to alcohol and some people who aren't sensitive at all to alcohol. And you can't predict that ahead of time. So as with most sort of medications or drugs, we need to really do a sort of a trial and error approach to figure out what's going on with that individual patient. And here's where it gets really interesting, and here's why I suggested that most of the recommended doses are wrong. And this has been known for a long, long time. Louis Scheiner in 1991 said, the dose studied is a dose almost guaranteed to be excessive. And what he meant by that is the dose that is studied in the initial FDA or Health Canada or whatever approval process, the dose that has to be chosen has to be at the top of that dose response curve. Otherwise, you likely wouldn't be able to show that there was an effect. Or if you use doses at a lower part of that curve, you'd have to use larger numbers of people to be able to show an effect. So typically, when you see a new medication on the market, you'll see it comes as usually 2 doses, and sometimes not even 2 doses, sometimes 1, but you'd see 100 and then 50. And the problem is almost no studies are done to examine what goes on in that lower area of the curve. So typically, you will not see 5 milligrams studied in the initial approval process. You'll just see 150, maybe 25. And for that reason, the drug companies, when they do a study and show that 150 have an effect, that's the dose that has to go in the monograph. You can't say, yeah, we studied 100 milligrams and a 50 milligram dose, but go ahead and start with 5. It's not the drug company's fault. It's actually not the regulatory body's fault. It's the sort of systematic flaw that we have in our drug approval system. And a number of other people have also talked about this. Drugs are often introduced at a dose that will be effective in around 90% of the target population. And as was reported in 2002, there is a systematic flaw in pre-marketing dosage evaluation. And it's a common practice that's undertaken in these phase 3 trials that evaluating the drug effectives is at the near maximum tolerated doses. And so whenever you see, especially a new medication coming on the market, the doses will often be much higher than are needed for the vast majority of people. We talked about this in an article we published back in the CMAJ in 2011. And all of the examples that I'm going to show you over the next few minutes are actually examples from specific RCTs that have compared higher doses to lower doses. Now, Not every medication has RCTs of higher doses and lower doses, but these are just a few examples that I think will be somewhat informative. For instance, hydrochlorothiazide, when it first came on the market many, many years ago, we actually used doses upwards of 200 milligrams. But now we know, at least for the blood pressure lowering effect, we know that 12.5 is as effective as 50 and as effective as 100 milligrams. Fluoxetine is an interesting treatment. Obviously, fluoxetine is an SSRI or an antidepressant. And there are a number of studies showing that 5 is just as good as 20 and just as good as 40. Now, there are clearly some people who will not respond to 5 but might respond to 20 or 40. But the general gist is that lower doses are, on average, just as effective as some of the higher doses. Ibuprofen for one, I guess you can use it for depression, but also for smoking cessation. There are a number of studies showing that 75 milligrams is just as effective as 150. So I'm not even saying it's less effective. It is as effective as 150. Varenicline is another medication that's used for smoking cessation, and there's a couple of studies showing that 0.5 milligrams is as effective as 1 milligram. And this is known by a lot of people, and even the FDA knows of these sort of studies. Unfortunately, their recommendation of the dose was this: Varenicline 0.5 milligrams BID appears to work as well as Varenicline 1 milligram BID. And then they say, sort of an asinine comment, is that so that subjects who cannot tolerate Varenicline 1 milligram BID should take Varenicline 0.5 milligrams BID. And I think anybody sort of thinking about that realizes that doesn't make any sense. Why start with 1 when 0.5 is just as good? Because then at least you have a chance of having less side effects. So this is where it even gets convoluted in FDA recommendations. Ranitidine, a medication, an H2 receptor antagonist medication that's been used for years and years and years. I've seen doses of 150 up to 300, but there are over-the-counter doses and so on. And there's reasonably good evidence that 25 is just as good as 75 and is just as the same effect as 125. So again, why would we not start with 25 milligrams in a condition that's not life-threatening? Sumatriptan for migraine prevention, when it first came on the market, it was a 100 milligram dose. And since that time, there have been a number of studies showing that 50 and 25 are probably just as effective as 100 milligrams. But you would never know that from when the medication was first put on the market because it only came on as 100 milligrams. And only over time and experience, and in this case, clinical trials, are we able to show that 25 and 50 and 100 are just as good. This is an interesting one. This is ezetimibe and its ability to lower cholesterol. And in this case, I'm going to show you a dose that is not quite as effective as the full dose. But interestingly, there's a study showing that if you take a 40th of ezetimibe, it still gives you 50% of the effect that you'd see with 100 milligrams. Again, a very good demonstration of the fact that we don't know what doses to use, especially when we're talking about low doses. Doxepin is another really good example. We don't see much doxepin used anymore, but when it first came on the market, it was an antidepressant. And then we found out that it causes sedation. So, of course, as soon as a medication has a side effect that you think you might be able to use, people started to use it for insomnia. And the recommended dose was typically what they called a low dose, and it was somewhere 25 to 50 milligrams for insomnia. And subsequent to that, though, a study of 1, 3, and 6 milligrams compared to placebo showed that 1, 3, and 6 milligrams all have an effect for insomnia above placebo. So again, a really good example where we used much, much higher doses than we really needed to. Sildenafil is another really good example. When it first came on the market, 100 milligrams was the recommended dose for erectile dysfunction, but many people and a number of studies have shown quite clearly that 25 and 50 are just as good as 100. And in fact, a number of people, I wasn't able to find any studies in this, but doses of even a half of 25 or even a half of 12 and a half are effective for erectile dysfunction. And it's all because of this whole concept of the dose response curve. Ibuprofen is an interesting example. There's studies that show that for migraine headache, 200 is just as effective as 400. Now, some people will swear that they need 400, and that's totally fine. But many people might take 400 when 200 would be just as effective. Colchicine is another really good example of how we screwed up in the past. We used to recommend for the treatment of acute gout is that we would give colchicine every hour until they either developed GI complications or had pain relief. Now, because the pain relief associated with gout doesn't go away that quickly, even with colchicine, most people we were dosing until they got really, really bad GI side effects. And interestingly, a number of years ago, a company that was looking at license or relicensing colchicine tablets decided to do a study to show that a lower dose was just as effective for acute gout. And they showed that 1.8 milligrams was just as effective as 4.8 milligrams with far less side effects. Instead of getting about 70% of people not tolerating it, it went down to, I think, about 25 or 30%. So exactly the same effect with less side effects. We've seen dose response curves with ferrous sulfate treatment for anemia. There have been a few studies, especially in elderly, showing that doses of 15 milligrams of elemental iron, and typically you can only do that with a liquid preparation, but it's shown that for correction of anemia, that 15 was just as good as 50 or 150 and considerably less GI side effects. So why is all this important? Well, more than 80% of all adverse drug reactions are that cause admission or occurring in a hospital are dose related. So if we were to use this principle that I'm talking about and start with much lower doses and likely to get exactly the same effect, we could probably get rid of many of the adverse drug reactions that we're seeing, because they are almost, like I said, all dose related, and they're really just an accentuation of that known pharmacological effect, and actually are quite predictable. And I think using these concepts, they are potentially avoidable. So we know 100 is going to give you pretty much the same effect as 50. So if you're really concerned about it, just start with much lower doses. And the reason that I'm saying that is that pretty much everyone is a genetic mongrel. Go back to the example when I was talking about alcohol. We cannot predict what is the right dose of alcohol for people. And we cannot predict what is the right dose for anybody, for any medication, for any condition. It's almost impossible. And here's what's really interesting. We see a similar dose response curve when we use virtually genetically identical animals. For instance, rats, which are exactly the same body size, gender, they're almost identical. We still see dose response curves in those. So you can imagine the type of dose response curve that you would see in all of us with our sort of genetic background. So, as I said, we published an article on this a number of years ago, and our bottom line was, unless the condition is severe or life-threatening, drug treatment can be started at a very low dose. And by that, we're not talking about go low, go slow. We're talking about taking a half or 1/4 of the recommended starting dose, and in general, maybe even taking a half or 1/4 of the lowest available dose and using that to start for conditions that are not life-threatening. Because much of the effect of a medication comes from that low starting dose, as I've tried to show you with the examples and the pharmacology behind the whole dose response curve. And when you double the dose, it almost never doubles the effect. And in fact, it sometimes has no additional effect. And so that's why for many conditions, people recommend you don't just keep bumping up the dose for things like hypertension or asthma or so on. What you do is you start with low doses of 2 medications. And that way you're more likely to get an effect. So I've tried to describe some of the issues around a dose response curve. I've tried to provide you with a large dose of common sense. So most of the recommended doses for non-life-threatening conditions are too high for most people. The drug approval process has a fundamental flaw in it that almost guarantees initially recommended doses are too high. Most side effects are dose-related. For most conditions, there is no urgent hurry to get an effect. And there is nothing you can measure or assess that will allow you to figure out the correct dose for a specific patient. It's all trial and error. And what we need to do is give the patient the freedom and the approach to figure out the best dose for them. And one of the cool things is, if you start with very low doses, it removes almost all the issues around what is the person's kidney or liver function. And almost all drug interactions become inconsequential when you do this. So you may as well, if you're treating non-life-threatening conditions, which is probably the vast majority of things that you're doing on a day-to-day basis, start with very low doses, say maybe a half or 1/4 of the typical doses that you've been starting off with, and then allow the patient to titrate up, either based on effect if there's an endpoint that you can measure, or at least to tolerability, so that if there's a particular dose that you're trying to get to, at least they can get to it slowly, and that will reduce the chance of side effects. In my experience, this approach is very, very well received by patients because it gives them a sense of control and that they can adjust the doses based on their response rather than a predetermined dose that has some fundamental flaws for why it was chosen in the first place. So I hope you found this information useful. I promise you it will have a dramatic effect on how you practice if you think about the different principles and follow them. So I think I'll leave it at that. So thanks as always for listening.